gynecologist. I want to give the lecture on the pelvic inflammatory disease. Maybe it will take two or three episodes. Now we are going to start with Quran verses. Bismillahir Rahmanir Rahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Allahumma inni as'aluka ilman nafiyan rizqan tayyiban wa amalan mutaqabbala shifa min kulli da. Pelvic inflammatory diseases, which is in short abbreviation we call it as PID. When we classify genital tract infections according to the etiology, specific, that is caused by Neisseria gonorrhea and tuberculosis, non-specific caused by Staphylococcus, Streptococcus, E. coli, Proteus, Chlamydia trachomatis, Mycoplasma hominis, viruses, etc. According to the clinical picture, acute and chronic, we will divide it according to the acute and chronic. Classification of the genital tract infections. C. According to the localization. Local genital tract infection, that is the vulvovaginitis, cervicitis. Upper genital tract infections, that is the salpingitis, endometritis, pelviperitonitis. D. According to the history of the recent delivery, purpureal and non-purpureal. So this was the classification. Now, definition. PID, it is the spectrum of the infection and inflammation of the upper genital tract organs, typically involving the uterus, endometrium, fallopian tubes, ovaries, pelvic peritoneum, and surrounding structures. It is attributed to ascending spread of the microorganisms from the cervicovaginal canal to the contiguous pelvic structures, causing endometritis, salpingitis, pelvic peritonitis, or tubo-ovarian abscesses. The cervicitis is not included in the list. The clinical syndrome is not related to the pregnancy and surgery. You can see this picture. In this picture, the diagram, it shows normal fallopian tube on one side, and ovary, and then the uterus, and then this part, it shows the inflammation. That is, these are the adherents, and then is the inflamed fallopian tubes, and then you can say you can compare the size between the normal and the inflamed fallopian tube. सदा न बागे बुलबुल होवे सदा न मोजे बहारा सदा न मापे हुस्न जवानी सदा न सोहबत यार. So no time, nothing is permanent, everything it is temporary. If there is disease, it can be treated and inshallah it can become normal. So nothing is permanent. Epidemiology. The incidence of pelvic infection is on the rise due to the rise in sexually transmitted diseases. The incidence varies from the 1 to 2% per year among the sexually active women. If you see this diagram, and you can see it is about 85%, they are spontaneous infection in sexually active female of the reproductive age. The remaining 50% follow procedures including the endometrial biopsy, uterine curettage, insertion of the IUD, and hysterosalpingography. And also, we cannot forget the septic abortions, induced abortions under this category. So this pie chart, you can see 85% spontaneous infection in sexually active female and 15% following the procedures. Again, two-thirds they are restricted to the young women of less than 25 years and the remaining one-third limited among 30 years or older. Again, this pie chart, it will shows you around about approximately one-third is 30 years or older and two-thirds less than 25 years. Risk factors: menstruating teenagers, multiple sexual partners, absence of the contraceptive pill use, previous history of the acute PID. So once there is history of the acute infection, there is, of course, it is one of the risk factor. IUD user, IUCD, intrauterine contraceptive device, area with high prevalence of the sexually transmitted diseases. This is again is one of the risk factor. Protective factors. What are the protective factors for the pelvic inflammatory diseases? Contraceptive practice and other practice, we have to weigh out the risk factor and the protective factors. When we see the contraceptive practice, that is the barrier methods, especially condom, diaphragm with spermicides, oral steroidal contraceptive, they have preventive aspects. That is the number one, produce thick mucus plug, preventing the ascent of sperm and bacterial penetration. Number two, decrease in duration of the menstruation, create a shorter interval of bacterial colonization of the upper genital tract. Monogamy, or having a partner who had vasectomy. In others, pregnancy, menopause, vaccines, hepatitis B and HPV, human papilloma viruses. Microbiology. Acute PID is usually a polymicrobial infection caused by organisms ascending upstairs from the downstairs. The primary organisms, they are sexually transmitted and limited approximately to Neisseria gonorrhea in 30%, Chlamydia trachomatis in 30%, Mycoplasma hominis in 10%. Microbiology. The secondary organism normally found in the vagina, they are almost always associated sooner or later. These are number one, aerobic organisms, non-hemolytic Streptococcus, E. coli, Escherichia coli, group B, Streptococci and Staphylococcus. Number two, anaerobic organisms, bacteroids, species, Fragilis, bovinis, and Peptostreptococcus and Peptococcus. Mode of infection. The classic concept is that gonococcus ascends up to affect the tubes through the mucosal continuity and contiguity. This ascent is facilitated by the sexually transmitted vectors such as sperm and trichomoniads. Reflux of menstrual blood along with gonococci into the fallopian tubes is the other possibility. Mycoplasma hominis probably spreads across the parametrium to affect the tube. The secondary organism probably affect the tube through the lymphatics. Rarely, the organisms from the gut may affect the tube directly. Pathology. The involvement of the tube is almost always bilateral and usually following menses due to the loss of genital defense. The pathological process is initiated primarily in the endosalpinx, that is in the fallopian tube. There is gross destruction of the epithelial cells, cilia and microvilli and may becomes edematous and hyperemic in severe infection. Next, the exfoliated cells along with the exudate pour into the lumen of the tube and agglutinate the mucosal folds. The abdominal ostium is closed by the indrawing of the edematous fimbria and by inflammatory adherence. The uterine end is closed by congestion. The closure of both the ostia results in pent-up of the exudate inside the tube. So the tube becomes blown up with the exudate. Depending upon the virulence, the exudate may be watery producing hydrosalpinx or purulent producing biosalpinx. That is pus, it is filled up with pus. The purulent exudate then changes the microenvironment and favors growth of other organisms, resulting in deeper penetration and more tissue destruction. There will be adherence of the tube with the surrounding structures. On occasion, the exudate pours through the abdominal ostium to produce pelvic peritonitis and pelvic abscess, or may affect the ovary, producing ovarian abscess. So, ovaries are also involved and there is abscess around it. Clinical features, symptoms. Patient with acute PID present with a wide range of non-specific clinical symptoms. Symptoms usually appear at the time and immediately after the menstruation. So, menstruation is the very important for the female cycle, and this is the time that is immediately after the menses one can catch the infection. Bilateral lower abdominal and pelvic pain, which is dull in nature. The onset of pain is more rapid and acute in gonococcal infection within 3 days than in the chlamydial infection, that is around 5 to 7 days, that is 1 week. So, gonococcal and chlamydia infection, if you compare, it will be the at least half time in case of gonococcal infection, and it becomes double in the case of chlamydial infection. There is fever, lassitude, headache. Irregular and excessive vaginal bleeding is usually due to associated endometritis. Abnormal vaginal discharge, which may become purulent or copious. Clinical features, again we are continuing with the symptoms, that is the nausea and vomiting, dyspareunia, painful menses, painful coitus. Dyspareunia, painful coitus, that may be superficial and can be deep. Pain and discomfort in the right hypochondrium due to concomitant perihepatitis, that is Fitz-Hugh-Curtis syndrome, may occur in 5 to 10% of the cases of the acute salpingitis. Liver is involved due to the transperitoneal or vascular dissemination of either gonococcal or chlamydial infection. Clinical features. Signs. The temperature is elevated to beyond 38.3 degrees centigrade. Abdominal palpation reveals the tenderness on both the quadrants of the lower abdomen. The liver may be enlarged and tender. Vaginal examination reveals, number 1, abdominal, that is abnormal vaginal discharge, which may be purulent. Number 2, congested external urethral meatus or opening of the Bartholin ducts through which the pus may be seen escaping out of pressure. That will be escape. When you apply pressure, it will escape out. Speculum examination shows congested cervix with purulent discharge from the canal. Bimanual examination, which is a very important part of the examination, it should never be neglected on the behalf of healthcare worker and also on the patients. Bimanual examination reveals bilateral tenderness on fornix, palpation which increases more with the movement of the cervix. There may be thickening or a definite mass felt through the fornices. Again, in clinical features of the acute PID, if we see that it includes the fever, 38 degrees centigrade, bilateral lower abdominal tenderness with radiation to the legs, abnormal vaginal discharge, abnormal uterine bleeding, deep dyspareunia. It can be superficial in the beginning, but if it is acute, it can be deep dyspareunia. Cervical motion tenderness and adnexal tenderness on bimanual examination. So, now I am going to end up the first episode of lecture on PID, and inshallah I will continue with the rest of its association treatment, investigations and all other criteria. Jazakallahu khair.